Hi, thank you very much for joining us. Today I have Chris Myers, a physiotherapist and musculoskeletal sonographer from London. Chris is a physio and osteopath by trade, and he is a musculoskeletal sonographer. He is the director of SMUG, the Sports Musculoskeletal Ultrasound Group, and he is a prolific trainer of musculoskeletal sonographers in the UK. Thank you very much for joining us, Chris.
Thanks, Dan, and thanks very much for the invite.
Not a problem. The idea of today is for us to chat and have a bit of a discussion. And, I want people to understand a bit about you, your background, where you came from, and really what's happening in the United Kingdom in terms of how are you training your sonographers? What's the certification? What do people need to do? And what do you think we can do better? So I might lead off with that, Chris. What's your background? How did you get into musculoskeletal ultrasound?
Yeah, so I trained as a physiotherapist first about 25 years ago now, and loved being a physio, worked in the NHS for a long period of time, which is our state system, and really enjoyed the job, but got frustrated with not knowing the answers. There's a lot of guesswork in what we
Yes.
do, educated guesswork, but it doesn't matter how good your clinical assessment is. If you want a specific structural diagnosis for a lot of conditions, not every condition, but for a lot of conditions, and you want to know a little bit more, then imaging obviously plays a role. And quite early on in the NHS, I was exposed to this, as many of us were actually, through the Australian group who started looking at transversus abdominis. And we started using a very old ultrasound. Yeah. I'm not sure that did as much good as physios, but anyway, it certainly introduced me to ultrasound. So we had this terrible machine that in hindsight, I mean, we probably just about saw transversus. And we started using it as a bit of feedback. That was my first introduction to it. And then I went off and did my master's in sports medicine about 8 or 9 years after I'd qualified. And I again got exposed to ultrasound, but only certainly not like you see it now in the program, just in terms of looking at images, having a little bit of a play. I remember having a bit of a play and thinking, like, this is really cool. Like, this is potentially something that I've been looking for to try and improve my practice. I then went back. I was still working in the NHS. I was working in sport and a bit of private practice. And I remember the conversation, and one of our colleagues, Rob, who does a lot of teaching as well, came in and said, look, something like there's £35,000, and if we don't spend it by the end of this week, the podiatrist will get it. It was something like that.
Yep. Yeah.
And Rob had been exposed to yeah, and Rob had been exposed to it as well. Anyway, we ended up getting this machine. I remember we had a Siemens Acroson something. Anyway, again, at the time, wasn't a bad machine. In hindsight now, you can't see a thing. But, and we started scanning, and it was very unregulated. Well, it's still unregulated, isn't it? But it was very much just having a go and seeing, I don't know, where it went. We had a manager that trusted us, that thought that this was a good opportunity. And quite quickly, when you start to scan, you realise you can't blag it, and you don't want to blag it. And actually, to get good at ultrasound takes time. And one of the best ways of doing that is to join a structured competency-based program. And therefore, a few of us in the clinic started the postgraduate certificate in musculoskeletal ultrasound. So this is now about 15 years ago.
Yes.
So there was only 3 of us on the course that were physios. There were not many physios at all doing it. Rob Louse, who I run SMUG with, he was our supervisor. So he's been doing this now 25 years. So he really saw something a long time ago. Yeah, and he had a lot of barriers to learning because he wasn't allowed on the radiology courses. Obviously, there weren't courses for physios and other people scanning. So yeah, anyway, he found his way through, he supervised us, and we got the postgraduate certificate. And I think, it was a massive turning point for me, as I'm sure it was for you, in terms of finding something that I felt I had real longevity with. And I still feel like that. I've been scanning 15 years, and I still, every time I put on the ultrasound, if I see something interesting, I just still think it's completely awesome that there and then I can just get that information. And patients, they love it. I work in private practice. It's one of the best things we did was implement diagnostic ultrasound. And then since then, and I think this is quite an important point, and I think you've probably, I don't know your career pathway, but I can imagine you've come across this, which is, at the time I was still doing ACL rehab, I was still seeing back pain, I was still seeing neck pain, I was still seeing things that, let's be honest, ultrasound has very little role with. And so
Yes.
you have to then develop your practice in a way where, one, you're going to get good at ultrasound because you need to get exposed to lots of pathology and you need to get the right cohort for what you see. And so quite quickly, you have to be prepared to de-skill in certain areas because you are therefore upskilling in other areas. And, if you ask me to, rehab a neck pain or something like that, or do the end stage return to sport of an ACL, in my practice, I've got people that are way more interested in doing that and way better at it than me. So you just have to be prepared that if you want to implement ultrasound, in my opinion, you're taking yourself down a diagnostic route. And in the UK, obviously a guided injection route, which we can talk about from a physio perspective. And once you've sort of happy to do that, then obviously your practice develops in that way, whether you go and do a sonography role, which you can do as a physio in the NHS, just an MSK sonography role, or whether you go into what we call a first contact practitioner, where you're doing a lot of the diagnostic workups. And you have to be prepared to go down that route. What I've done is I left the NHS, I did all my training in the NHS, I set up a private practice, and as soon as you start implementing ultrasound into your practice, you start attracting the patients that they feel you've helped. Because, for example, you see lots of shoulders, you scan shoulders, we know ultrasound's amazing for shoulders, and therefore they then say, oh, go and see Chris, he does ultrasound and you've got a shoulder problem. So it's very rare now that I will get a referral for ACL. We get loads into the practice, but they do not get addressed to me, rightly so. And for back pain, I'm very much seeing peripheral sports injuries, which is exactly what I want to see. And so by adding ultrasound, not only am I attracting the people I want to see, I feel I'm also using my expertise with the patients that I can help the most.
Yeah, I believe, subspecialization is such a good key to being a good clinician. It's so hard to be a generalist, to know, everything about everything. Subspecialization really helps. And, the role of imaging with that, I think, is a very big key. The background. So in terms of the people that do the certificate in musculoskeletal ultrasound, what do they need to have under their belt to get entry into that?
Yeah, absolutely. So let's just go back a little bit, and I think it's the same for you guys, but the term sonographer, the term musculoskeletal sonographer, who can start scanning is completely unregulated in this country.
Right.
Any physio can go and buy an ultrasound machine and in theory start scanning. Any sports doctor can buy an ultrasound machine and in theory start scanning. Osteopaths, chiros, GPs, orthopedic surgeons, obviously sonographers, radiographers, slightly different actually over here in terms of they would need to go and do a sonography training, podiatrists, sort of you name it, anybody that's involved in MSK care could in theory could buy an ultrasound machine and get started. In terms of who would get onto the postgraduate certificate, from our point of view, we like clinicians that are experienced, that obviously have the right qualifications, that are members of the associations. But to give you an idea, on our code, we had 42 this year. It was literally what I just said: podiatrists, radiologists, orthopedic surgeons, physios. Everybody involved in MSK care is looking to add ultrasound. In theory, can join an MSK ultrasound postgraduate certificate, as long as they've got the right experience, the right qualifications, etc. So what you've got, which is really exciting as somebody that's involved in ultrasound, but at the same time it is very worrying, is that it is very poorly regulated in this country. And the physiotherapists, so the Chartered Society of Physiotherapists, the Faculty of Sports and Exercise Medicine, so the sports docs, they all have documentation around what you should be doing to get a competency within ultrasound, and we can talk about that. But there's no checkpoints, there's no auditing going on, there's no regular recertification, and actually, although they're saying here's the document to you for you to follow, there is, from what I can see, unless somebody tries to sue you or complains about you, there's nobody then going, actually, has this person got the right qualifications in the first place? Does that make sense?
It does. Yeah, it definitely
Yeah.
does. In Australia and New Zealand, we have a similar kind of situation. But yes, any man off the street can go up and buy an ultrasound machine and use that within their clinic. The inhibitor of that a lot of the time is if they do that is fine, but the way that they will bill to remediate for their time for their purchase is going to have to be implied onto the patient. And if you are an unregulated person, then that person is your patient is paying a fee for that. Whereas we have both in Australia and New Zealand, we have, if you're in a radiology setting, a lot of the time, if you have a request from an appropriately trained clinician, then you will receive a contributor of that fee from the government. So New Zealand has the ACC, Australia has Medicare, and they will receive a Medicare rebate, and in a lot of places that will cover the cost of it.
That's the same for physio as well, because that's Medicare as well, isn't it?
Yeah, interestingly. So in Australia, if you get a physio referral for an ultrasound, that does not attract a Medicare rebate. So physios cannot...
What about the physio doing the ultrasound? That doesn't happen, does it?
No, that doesn't happen. That needs to be done in a radiology setting under the supervision of a radiologist. So even though a sonographer does the examination, some of the rules are being changed just last year. A radiologist needs to be on site or available for consultation. It used to have to be. They used to have to.
Yeah, I remember people saying that in Australia, and it sounds like it's moved forward, that you guys do the scan and then the radiologist reported on the scan.
Correct, and that's still the case.
That is backwards, Dan.
Yeah, it's interesting. There's been a lot of work for advocacy, but
yeah, I mean, and I'm saying that not to insult radiologists. I'm saying that ultrasound is a dynamic assessment. It needs, to a certain extent, some sort of clinical assessment, and to retrospectively review scans, which is what I do all day long for people training, is really difficult. And unless you're scanning that person yourself, you're missing. You've got that potential to get the wrong end of the stick.
Yeah, you need your hand on the probe, really, don't you, to be able to figure out what's going on and make sure that correlates with the patient's problem. Traditionally, the radiologist had to personally attend the patient. Whether that happened or not was, often didn't. Often the radiologist was just memory reporting MRs.
Yeah.
But some of them were very, very good. So, there's a spectrum, same as anything. So some were fantastic. Some were excellent clinicians and would see every patient, have a look, and they could scan as good as anyone else. Others did not have a great deal of interest. And that's still the case. So, primarily in Australia and New Zealand.
Similar to America, I believe, that model, isn't it?
That's right, it is. So, we've still got a little way to go and quite a bit of advocacy to go.
Yeah, so it's interesting. So it sounds like, obviously it's different over here because we have the NHS and we have private practice.
Yes.
And so therefore it is very different. Now in the NHS, when people are training, they often get good access to radiologists, they could get good access to supervision, and essentially, as long as their standard operating procedures and their local policies are up to date and in collaboration with often radiologists or other departments, then you've got that real protected environment where you can start scanning, and obviously everything's free at the point of care, so there's no money exchanging hands, which always makes things a lot more straightforward. Now, when it comes to private practice, and obviously I've done both, when it comes to private practice, as a physio or as a podiatrist, as a clinician that is a non-doctor and not a sonographer, you can't really charge separately for an ultrasound scan. And this is where it gets quite grey. So if you come to see me with shoulder pain and I charge you, I don't know, £75 for an assessment, I can't then charge you £100 for an ultrasound scan. So because then you're separating the ultrasound from the assessment. You're not necessarily doing it in real life, but in the patient's eyes, you have marketed yourself as two separate things. Now, we are not insured as physiotherapists to work in that way. It has to be a continuation of your clinical assessment.
Okay.
So therefore, for example, in private practice, I might charge, say, £150, and that includes your clinical assessment and, if appropriate, an ultrasound scan. If you start differentiating it, essentially you're working as a sonographer, which is fine if you've then got the appropriate insurance outside of physiotherapy insurance to cover you for that. Now, as a physio, I'm very much an MSK physio, and as I've been doing it quite a long time, of course, if a funny looking lump and bump comes up or there's something I'm not very happy with, as you get more confident, you get more confident with those things that are they're still in your scope of practice, but slightly outside that initial scope of practice of MSK. Now, we don't have that breadth of knowledge that you guys have, because as we were saying, is that you will train as a sonographer where you're doing everything.
Yes.
Whereas we are very much training in MSK, and we all know there's overlap. You know, you scan a calf and suddenly you see a DVT, or you scan a groin and you see lymph nodes. So there's always that clinical risk. And that's where the whole system gets difficult, is that we're supposed to be using an extension of our clinical assessment, but we know until you look under the skin, you can't be 100% sure what you're going to come across. And you do come across things that are either not appropriate, not relevant to their pain, or you come across such as incidental findings, which we know is quite common, or you come across something that completely explains their pain but is not musculoskeletal. So it's difficult. It's difficult because our training is not the breadth that you guys get, yet we all know as you get more experience, having that breadth is really, really helpful. But as soon as you start giving yourself more breadth, you're then not working as a physio with an extension of your clinical assessment.
No, it all makes sense. Yeah, it's always a challenge, isn't it? You know, working within your scope, knowing your limits, knowing when to refer on. I think that's one of the biggest teaching points. In terms of training in the UK and doing your postgraduate certificate that you guys do, what's the advantage of having that apart from having the skill set?
Yeah, so we all know that you can learn ultrasound on your own. I mean, you can do, you know, I always say it's like playing the guitar. You don't have to go to university to play the guitar. But what going to university does give you is it does give you a structured learning program, which ensures that you do cover the breadth that is required. And you also cover the professional issues, the physics. So you get a nice structured learning pathway that has deadlines. We all need deadlines. Or some people do. Probably 99% of us need deadlines. So you're going to reflect a lot on what you're learning. So as a learning experience, you get an awful lot out of it. And in that year, you will develop a huge amount. So, but bearing in mind, you only come to university 8 to 10 days. So we have lots of online lectures, we have lots of good information, and we cram it in, and we try and spend as much time as possible as we can in those days and teaching people how to scan, but very much covering the professional issues, the scope of practice, the what to do if you find something you've got no idea what's going on, and trying to get people to understand their limitations, but also going through physics, going through instrumentation, going through parameters, you've got to obviously cover that in your basics. Now, So we can do that, and we do that with everybody on the PG cert. And as you know, the key part is going to be the clinical supervision. So for us, they have to have a clinical supervisor that goes through the course with them, and that's obviously, you know, somebody that they're spending a lot of time scanning with, and they have to get 250 scans, if you like, signed off.
Yep, the
A
logbook.
hundred of Yeah, a logbook. 100 of them is supervised or assisted, which is where, say, for example, we were scanning together. I was the student, Dan. You'd be like, oh, yeah, you could do that. But when you do supraspinatus, do that. So lots of assistance. They have to have 100 of that. So you generally do that more at the beginning of the course. And then you have to have 150 unsupervised or unassisted scans. So the term unsupervised we used to use, but we're trying to come away from it because you should not be unsupervised through your learning period at all. So it's really an unassisted scan that they report on, you report on it, and then on our course we get them to do an agreement score. You know, completely agree or completely disagree, and could be detrimental to patients. You know,
well-being,
treatment.
health. Yep.
You know, like you missed an Achilles rupture, something like that.
Yep.
Or you've missed a lump and a bump that, you know. So then they have to do their 150 unassisted.
Yep.
And
So with
look,
those, Chris,
yeah.
do you need to cover certain body regions, or is it just general?
Yeah. So it can be whatever you want it to be. So, for example, we had we had two shoulder surgeons on the course this year, and they will only do shoulders. So their 250 scans are shoulder scans, and therefore their competency and their scope of practice after the course is shoulders. And if they want to increase their scope, they can go to elbows, but there then has to be there has to be more more assisted, more unassisted scans, documentation. And actually what you should do is just keep your logbook going, which we then turn into your POP, which is your portfolio of practice. So if you said to me, Dan, how have you got any sort of scope to start scanning, I don't know, some vascular stuff, which I've started doing a bit more of, and I'm not a vascular sonographer, but I found 3 DVTs this year in calf tears. So you think, well, actually, if I'm going to scan the calf, I've got to have some idea. So we had somebody come in and they taught us a bit. We've now started documenting any scans where we've looked at vascularity, but again, that's under supervision. So I've got somebody that I can send those scans to and they can report back. And we're going to go to sort of 20 scans of the calf. You could go to 50. The numbers out there are completely unknown. But we thought with our experience, we just wanted to document 20 scans where we've done a calf, just for the calf, that we've just done a basic thing that we've gone through. So you can increase your scope of practice. It does become grey, but whatever you do, you need to prove your scope of practice. Okay. But you can't then, I would never then offer a vascular service, ever.
Yeah, so you can kind of
build it. That we happen to find it, and therefore, because we're very, from our clinical governance point of view, we're very on this for lots of reasons. And we would then, not necessarily increase our scope of practice, but just have more information in that area. Yeah, and we're always going to refer off for a formal ultrasound if that happens. I'm never going to call a DVT and leave it at that. I think this is a DVT. Go to A&E, go and see this consultant, go and get an ultrasound. Because we are then, in theory, working outside of our scope of practice.
Okay, so you don't really build it up as a modular kind of component. With that, you'd definitely stay away. Yep.
Your scope of practice, you can have a postgraduate certificate in musculoskeletal ultrasound, and if you're a podiatrist and you've done 250 foot and ankle scans, you still have a postgraduate in musculoskeletal ultrasound, but your competency is based around your logbook and your portfolio of practice, which I think works really well because it can be done modular. And it does give, in a year, how good can you get in a year? Like, you get okay. You get good at what you scan. You only get as good as your supervisor gives you that time and feedback. So some people go to the end of the PG cert and I'm like, wow, these guys are amazing, because we do exams with them, and then you get people that are literally scraping through, and all you have to ask them is, how much time have you spent with your supervisor, or how good, and they're like, well, I'm with them twice a week, scanning with them, and they're next to me. Well, no wonder you're brilliant. you know, or I only get the ultrasound machine on a Tuesday and a Friday, and I only get supervision half of that time. And you know they're gonna struggle potentially, other than the fact that some people are just so motivated they just get it. And it's like playing the guitar. If we all started to learn the guitar, we don't all get good at the same time after a year. Some of us will be terrible after a year, doesn't matter how much we've practiced, and some people will be brilliant and ready to go on stage. People just pick it up at different rates, like any motor skill.
Absolutely. No, we have a very similar situation throughout Australia and New Zealand, in that the training that you get will vary grossly between people. As we alluded to before we went live on this one, most people in Australia and New Zealand doing ultrasound are sonographers working in a radiology setting, and the training is all inclusive. So we do abdominal, vascular, obstetrics, gynae, everything except cardiac. Cardiac's its own little world in the corner. And so the university courses that people do will be a little bit all inclusive, but the actual hands-on training that you do will entirely be dependent on your practice where you train and the tutors that you have. So over here, I think it's something like 1,200 hours you need to do within your training. So it's about a year and a half full-time equivalent.
That's to cover everything.
Yeah, to cover everything. But some people are going to be working in, primarily a fetal medicine unit. Some people are going to be working extensively with vascular surgeons. Some people are going to be doing a bit of musculoskeletal work, and everyone's going to be, you're working in a public hospital. And over here, public hospitals don't see any musculoskeletal work, or very limited musculoskeletal work, but they're dealing with liver transplants, they're dealing with AV fistulas, they're doing all this complex stuff. So the skill set that people come out with are vast and varied, and then they change employers and go to other places, and they have to, be a bit of a generalist and have this skill set that they haven't been trained or supported with. They have to kind of pick it up on the go, and it can be very hard. It can be very challenging.
I think
one of the things that we have that I think you alluded to as well is that there's no kind of recertification process. There's no quality assurance as you go through. It's just you go.
Well,
and
in the UK, the only guys that have really got that is your sonographers, who it's not well regulated though. But they will say 5% of your scans a year should be audited, and I think a lot of departments will do internal peer audits, which is absolutely valid. But from a physio, I've been scanning 15 years. I've never had to, in theory, provide anything to anybody from a competency point of view.
so we don't do internal audits at all.
No, there you go. And we all know that actually audits are a really useful thing to do.
Absolutely. Self-reflection.
And particularly at the beginning, because what you've said there, Dan, is exactly what we're saying, which is at the end of the day, everybody's going to have a different scope of practice, and it is our responsibilities as individuals to be aware of our scope of practice. And I'm sure you're the same. The more experienced you get, for me, by far the more aware you are of your limitations, and that's probably what comes of being an experienced clinician, is knowing what you don't know. The problem when you're new to this, and where you have to ensure that you have support systems in place, be it a supervisor, be it an orthopedic surgeon that you can send to, or be it have a good relationship with their GP. Because, if you scan something and you don't know what's going on, you can't just leave it at that, can you? You've got to then ensure that is then seen by the right person, and particularly if it's something concerning. So you've got to just be aware of your scope of practice. And the problem is, people that are on our PG cert, they get very excited about scanning, but they have got no idea what they don't know and what they can't see. And so that's always the bit that worries me. And in the NHS, and I always say the NHS is a bit more of a protected environment, because first of all, if you get sued, they will protect you to a certain extent. In private practice, you're just being hung out to dry. You're on your own, and you've got to make sure everything's in place. And although look, the norm is that physios are still not scanning in this country. There's no doubt about that. We're still talking about a very small percentage of MSK physios that are scanning, but it is massively growing. And just the number of courses, the number of people on our courses, it is getting so much momentum. And that's really exciting as somebody that teaches ultrasound, but it's also really worrying. There's going to be a lot of people out there that are terrible at scanning, and you know, and not necessarily being complete, informing the patients completely that that's where they are in their stage of learning. So
Mm.
it sounds like you guys have actually got things way more regulated, and in a way, by saying physios can't scan, etc., etc., you are regulating that process. If I had a crystal ball, that I think that's going to change,
Yeah.
and that's when the regulation from the beginning needs to be in place, which my suggestion would be has to be a postgraduate certificate in MSK ultrasound, because you've got to make sure everybody's covered the basics.
I think that's a very good, very thorough idea. Something you touched on was, one, working within your scope of practice, and two, that kind of leads me on to being an independent prescriber. So in the UK, physios can perform injection therapy,
Yeah.
and so can podiatrists. Is that correct?
Yep. Yeah. It's slightly
Yep.
different with podiatrists, but yes, they absolutely can. Podiatrists actually cover that in their undergrad,
Yeah,
but we
podiatrists over
don't
here
cover it
can.
in undergrad. Yeah.
Right, podiatrists over here can do their own injections. Physios cannot, and the majority of injection therapy is done in the radiology setting. So sonographers cannot do injections. Radiologists
Right.
can. Right, so the
Yeah.
radiologist is the person that puts the needle in, and sometimes that's the only time a patient will see them, as they come in with a needle in their hand and do a little bursal injection and go, there you go,
Yeah.
have a great day,
Yeah.
and then
Yeah.
we
Yeah.
go back. But on the other hand, some are sensational as well.
Yeah. Yeah.
So, in terms of the regulation for doing ultrasound guided injections, how
Yeah.
does that
So
work?
yeah. So from a physio point of view, so sonographers can inject under ultrasound guidance over here. They would be like an extended scope sonographer.
Hmm.
That's not the right term, but so they can do it, but they're very much in an NHS department under supervision, or with other people around that they've got a they've got a support network. But fundamentally, they can do it. The only way they can get the medication is through a PGD, which is a patient group directive, which is where you basically, I don't know if you guys probably don't have it, but it's a document that's signed off by the pharmacist, that signs off by the medical consultant, and says if a patient walks in and you think they've got a subacromial bursitis on ultrasound, then you can go into the fridge or the cupboard and you can get 0.5 mils of this out, 2 mils of that out, and then you can inject it. So it's predetermined for a patient group. So that's how
Right.
sonographers do it. Physios can do it like that too in the NHS. Okay, they can do it privately if they've got CQC, blah, 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 but let's not go into that. But essentially, if you're going to inject, most physios now will do an independent prescribing course, which is actually a reasonably tough course. And again, what that is that on that independent prescribing course, you'll have physios, you'll have pharmacists, you'll have nurses, you'll have people that are extending their role and their scope of practice to prescribe medication. Now, when I go and do it, I will prescribe painkillers, so simple painkillers, because obviously we can't do that. Anything that's over the counter, we can obviously give some advice on, but anything that is prescription only, would be why you're doing this course. So on mine, I was doing some things like pregabalin, gabapentin, amitriptyline, anti-inflammatories, and then obviously on top of that, within my P formulary, which is my scope of practice, I would have the local anaesthetic and the steroid. Now, interestingly, when I was in the NHS, we were prescribing some of the other medication because we were part of a pain team. But actually, I haven't prescribed any tablets for probably 5 years, and I would now see that that's out of my scope of practice.
Mm.
So all I prescribe would be Kenalog or Depomedrone, which is the two steroids we generally use, and then local anaesthetic. So I'm literally just using that now just to prescribe the injection stuff.
Right. Interesting.
And then but the way it then works is we can't just have like a drug cabinet full of drugs. it still has to be done per patient. So if you come and see me and I assess you and you've got a shoulder bursa or whatever, or frozen shoulder, and I'm like, look, Dan, I think the best option for you is X, which would be a potentially an injection, then I will do a prescription for you that I then get sent from the pharmacist. So it's a specific prescription for a specific patient. You can't go bulk buying 200 steroids and you walk in and I just stick it in. So it is very much per patient, which is fine. When you've got a process in place, you can make that work. But yeah, that's how independent prescribing works. From an injection point of view, so I have this conversation with a lot of physios that go, oh, I want to do ultrasound guided injections. So you've got three things. One is, can you scan? And there is some regulation around that, and it takes time to get good at it. The second is you need to do your independent prescribing. And then the third thing is you need to be able to stick a needle into a patient. Now, physios in this country for the last 20 years have been doing injections unguided for lots of different MSK problems. So the idea of a physio injecting in this country is completely, in the NHS, which is where it started, is not, it's very normal, etc. It is different in private practice because you need to do the independent prescribing. So then you could go and do a course where you learn how to do, so we run a postgraduate certificate in ultrasound guided injections where we go through the pharmacology, we go through the side effects, we go through the precautions, we go through the contraindications, what to do if somebody faints, what to, all the drug interactions, as well as the technical side of doing the injection. So they could come and do a course like that, or they could, in theory, go off and do an unguided course still, where they cover the basics of pharmacology, etc. But they then, because they have their ultrasound skills, they then would probably do, for example, 10 seems to be the number. You then do 10 injections that are supervised and then you can inject. We all know to get good at ultrasound guided injections, probably I think takes about 150 to 200. And then if all you do is inject shoulders, you're good at in shoulders, but you're not good at hips. So again, it's that scope of practice sort of part of it. And that's it really. So the CSP, which is our Chartered Society of Physios, have two documents. They now have two documents, and it might be worth, it's quite an interesting read, and it's quite a nice guide for people that are looking to start out in ultrasound. They talk about the scope of practice of ultrasound, and they talk about the training that's required. And for many years, we've had a document around injection therapy and the training that's required. What we don't have, and we don't necessarily need, is something around when can you do ultrasound guided injections. It's more just an assumption that if you can do ultrasound and if you know how to stick a needle in somebody, then at some point those things are going to come together, and then you're probably good to go. What we would always recommend is, again, using this portfolio of practice or this logbook, which is where you would document that you've got to do some supervision, even if you can inject and even if you can scan. There's got to be a coming together. We run a cadaveric course, which is good for just starting that process. But essentially, somebody needs to sign them off, and maybe 10 injections is a good start. We don't know. For our guided injection PG cert, we do 35. But again, as we know, it's about scope of practice. If you do 35 knees, then your scope of practice is knees. And if you want to extend that scope of practice, you've got to go back to some supervision, and you've got to go back to documenting those injections.
No, so my last discussion point that I wanted to touch on a little bit, Chris, was, so we've spoken a bit about, the current way things are trained, the certification, and the way that's supervised. What do you think can be done better in ultrasound training? What's a better way of doing this?
Yeah. So it's really difficult, Dan, and I've been doing this for a long time.
It's a big question.
It is, but I do believe there needs to be more done. And I do think in this country it's getting there. That for me, if it doesn't matter what your background is, you're either good at scanning or you're not. Okay, you've got to be regulated, etc. There's two schools of thought. We get lots of doctors that are scanning. I get lots of radiologists, in theory, that have been doing MSK lists for many years and sonographers for many years, and fundamentally their skills are not good enough. So you've got your doctors that we sort of all assume have got the skill set, but a lot of them haven't. So I actually think, the Royal College of Radiologists have done a lot in this area, but there is still, overall, I think the standard of ultrasound in this country can massively improve, and I think it is. So for me, it doesn't matter what your profession is. I believe most people should be doing a postgraduate certificate in musculoskeletal ultrasound. And we have to accept that that means not everybody can scan because they can't get the supervision because they're not working in an environment where actually it's the right place for imaging. Because we all know imaging needs to be way more regulated than physio. And it is generally. But then when a physio or a doctor or a radiologist or anybody or a sonographer that hasn't got that basic training with that basic skill level, with that basic logbook that's been signed off, then I think there's without that there's too many ways of controlling. There's too many pathways that are uncontrolled, basically.
Yeah.
So if I was to write it, I would say I don't care what your job is. You need to be able to prove your training.
Yep.
I really do, and I appreciate that some people just pick this up and they've got a great consultant radiologist that's taught them everything, but actually, does it matter if we do a bit more training? Does that really matter? I don't think it does. But I think it's you either regulate it like that or you do what you guys have done, which is say you guys cannot do this. Physios can't scan, osteos can't scan, podiatrists can't scan. Now, in our NHS service, where we've got waiting lists up over a year, we've got 7.5 million people on a waiting list. We need to ensure that the right clinician, and we did this in the NHS, the right clinician sees the patient at the right time, and the right clinician is the one with the right skill set. I honestly don't care what you are, as long as you've got the skill set. So whether we're getting some physician's assistants coming on it. If it was a nurse, if it was a midwife, I really don't care. It's just not a midwife for MSK, but you know what I mean. It's just whoever's got the qualification, who can see that patient at the right time. What we can't do is what you guys are doing, because we cannot just have radiologists and sonographers scanning in the UK, because we cannot therefore meet the demand of MSK imaging. So there has to be this workforce development, which is happening, but needs more regulation. And once they regulate it, let's go for it. Physios in radiology, scanning, which is happening already, but they do well in MSK ultrasound because they've got the clinical sort of knowledge as well. So that's rough. I don't know if that answers your question, Dan, but something like that.
No. I think that's very true. Is that quality training is key. I would really like to see a degree of annual competence or internal audits are great. Currently in Australia for nuchal translucencies for babies, we need to maintain our certification, so we need to submit adequate images to an external body and they'll validate it. And I think that should be employed in a modular component. I think that'd be a very useful thing. But either is it done internally? If you're an accredited site, you do it internally. Otherwise, you send it to an external body, and they will have a look and they will accredit you.
Who do you send them to, Dan?
I think
Out of
that
interest,
who
do you send them to?
nuchal translucency. The nuchal
Yeah.
translucencies go to their own little body. I'm not qualified anymore, so I can't even remember for my nuchal translucencies. So there's an external auditing body. It's past me. But I think that would be a good thing, because I think the whole role of self-reflection and trying to get some things that you know are really good, like you need to get some good quality images. It makes all your other work jump up as well, because you're really thinking a lot more. You're trying to get some good ones for your case collection, and it makes every scan you do a little bit nicer, a little bit sharper, and you think a bit more, and maybe you read up a bit more and try to get onto things. So, I really like that as an annual or a 2 to 3 year process that you have to submit a logbook of your things to maintain your modular competency. I think that'd be a really good thing.
Yeah, I agree, and I think it feels like we're a long way from that in this country, but I think that has to be done. The problem with that system is the cost to the associations, like who's going to do it. Something that we're developing, or we are looking to develop in Smug, is exactly that, which is some sort of, we would only have it as a peer reviewed thing, because you've got to be careful that you're not, telling people they are or aren't competent. But if somebody wants to provide 20 scans, then we review them and we go, yeah, that's generally pretty good imaging, or you need to do this and X, Y, and Z. And I think we'd love to do something like that, because if we wait for the governing bodies, I mean, I don't think I'll still be scanning when what you just said comes into place for
Yeah,
physios. I
yeah,
might not be alive.
yeah. I don't see it being employed here either. But I like to dream.
Yeah, and it's part of the solution without a doubt. It is, but we do need some more regulation around it, because everybody, and actually, to be fair, clinicians are generally very conscientious. They want to do the right thing, and a lot of the time clinicians just need guidance, but unfortunately there has to be a consequence to that as well. It has to be that, well, you might, if you don't provide this, then you can't reaccredit, be it as a physio or anything like that. The other thing I'd like to happen in this country is that we have the physiotherapists that have the chartered society on top. We have podiatrists that have this. There's also something called the HCPC.
Yeah,
And when you become an independent prescriber, if you went on to Chris Myers on the HCPC, I've got a little independent prescriber next to my name. So I would like that for ultrasound. So and if you've got a postgraduate certificate and you've reaccredited, then you keep your name there. So independent prescriber, diagnostic ultrasound. We have to all realise that ultrasound and imaging increases your risk of getting sued. Like, there's no doubt about it. Imaging does that. The clinical risk goes up, and therefore that needs to be regulated. And if we don't regulate it soon, with the number of people that we're training, in 5 years' time, you're just gonna,
it's going to be a
the
fight.
standards are not going to be good enough, despite generally practitioners being conscientious.
Yeah. It's everyone's doing it with their best intentions. But you only
Yeah,
know what you know, and you don't know what you don't. So it's tough,
yeah,
isn't it? Chris,
yeah,
just one more thing before we wrap up. What's next for Smug? What's
yeah.
happening up next?
Well, we got lots of, probably because of the conversation we've just had. There's massive opportunity for teaching in this country. And we are constantly developing new courses and that sort of thing. We've got our September postgraduate certificate cohort, so that's already really busy. So that will be pretty full, I can imagine. And then probably the thing that's coming up is we've collaborated with Arsenal Football Club, which is obviously a big football club in the UK. I didn't quite win the Premiership this year, but did very well. And we're doing a 2-day sports medicine conference at the Emirates Stadium on Monday the 2nd and Tuesday the 3rd of September. So this is a 2-day course, and it's at the stadium, incredible sort of venue. It's going to be really cool. But it's not just for people that scan. It is a sports medicine conference. But obviously, we have invited people like Carlos Pedra over, Karim Silbernagel from the US, Johannes Roth. We've got Justin Lee from Fortius, Rowena Johnson, hip and groin. So we've also got quite a bit of imaging with an ultrasound bias in there. But then we've got probably 60-70% of the rest of the speakers. There's some surgeons. So we've got Andy Williams, James Calder, lots of sort of very well-known guys that are working in elite sport in this country. And we've also got physiotherapists. So we've got Tottenham physios, Arsenal physios, obviously, and we've got people from other sports as well, talking about return to play and ACLs. So it's a real,
It's an
it's quite a
incredible lineup.
broad.
Looks like a
Oh
really,
mate,
really good
it's,
meeting.
yeah, I mean, obviously I was involved in the lineup, but yeah, there's definitely no space for me on it, I can assure you.
Put the dream team together. If it goes
Yeah,
on a road show, bring it down
yeah,
under, and it'll be
yeah,
extremely
that would
well
be
attended.
great. That would be great. So I think that's going to be really good. And it's I'm really looking forward to it. Really looking forward to it.
No, I think it'll be an excellent meeting. Chris, thank you so much for your time. It's been great chatting
Pleasure.
again. And it's been great to get some insights as to what's happening in the United Kingdom, what's happening with ultrasound regulation, and what's happening with injection therapy. Thank you very much for tonight. Appreciate it, and all the best. Happy scanning, Chris.
Thanks very much, Dan. Thanks for the invite, and hopefully when it comes to regulation, watch this space in 2 years. We've got a lot more regulation as we discussed.
That's right. All right. Thanks very much.
Cheers, mate.